We'll be moving on to the next session, that is advances in diabetes management, the recent advances. I would like to invite the chairpersons, Dr. Arundhati Dasgupta, who is a director and consultant endocrinologist of Rudraksh Super Speciality Care, Shiliguri, Dr. Arvind Kumar Arya, who is the director of Bardhaman Hospital and Jamshedpur and a consultant physician and diabetologist, and Dr. Shubhajyoti Ghosh, who is practicing diabetology at Apollo Clinic, Dibrugarh. Over to you, sir.
So good afternoon, everybody, and welcome back to the post-lunch session. And very aptly to talk on a post-lunch session, we'll have the person who's leading from the front, Dr. Supratik Bhattacharya, talking about a combination of two molecules, insulin and GLP-1 receptor agonist, and their action. So nobody needs to see this to know Dr. Supratik Bhattacharya here. So without much ado, I'll call him on stage and ask him to start his talk.
Thank you so much. I know Dr. Dasgupta for a very long time. He's a very close personal friend, and it's a pleasure to have both her and Dr. Shubhajyoti here as the chairperson, and I'll keep my talk as minimal as possible because postprandial session is always a challenge. So, but I think it's a bliss, and we want to reduce the number of pricks, and the synergy that we have in terms of immaculate fasting control along with the prandial control is what makes this very special. So we know that sometimes in Indian scenario the basal insulin falls short. Why? Because in India most of the time is spent in a prandial state. So almost 18 hours in a day is spent in a prandial state. We have full meals for breakfast, lunch and dinner, and this is a big concern. So if you only target the fasting sugar with a basal insulin, that's probably not just good enough. We are also aware of the data that comes from the Western world, the Munir study, that if your HbA1c is very, very high, most of the contribution is from the fasting, and if you come closer to your target A1c, the contribution is more from the prandial sugar. But in Indian circumstances, unless you're addressing both the fasting and the prandial together, it's very difficult to get a hold of your HbA1c. So in India and type 2 diabetes, the burden is very high, and most of them go underdiagnosed, and even if they're initiated on some kind of a basal insulin, up titration doesn't really happen. And I've seen many of my patients who have been initiated on 10 units of basal comes back after like 3 or 4 years, and they're still using 10 units. So this is absolutely appalling and ridiculous. In spite of all the support that we have in hand, the counselors who are there on a day-to-day basis, following up and asking them whether they're up titrating their dose, getting to the target fasting, we see that they are falling short. So we need to be aggressive. We need to take care of the fasting and prandials together. So this remains the unmet need in advancing diabetes care. So we had basal insulin, we had basal plus, then we have basal plus plus and a full-on basal bolus. Or you could go the other way and you can start with the basal with a GLP-1 receptor analog, which not only gives you a fasting and a prandial cover, but also gives you many more pleiotropic benefits. So we know that if you only using insulin in that scenario, your weight is going to go high. So that is a burden in an individual who is already living with abdominal obesity. So if you consider a basal with a GLP-1, which mitigates all the ill effects that come with the basal, including the body weight, I think that is a welcome. So, the basal insulin like Lantus has gone very robust cardiovascular outcome trial to show that it is, safe for the heart. And then on top of that, you have another GLP-1 receptor analog, which, obviously lixisenatide is cardiovascularly neutral, so as to say, it doesn't show superiority, but GLP-1 receptor analogs as a class, as you know, is having many more pleiotropic benefits, as we'll talk about in the subsequent slides as well. Now, what opportunities could fixed ratio combination have? So A, multiple physiological defects can be addressed. Increased convenience, improved adherence. So this is very important. If you're offering a basal bolus therapy, that means a person has to take 4 pricks a day. It might be the ideal gold standard, but imagine a person who has never been on any injectable being asked to take 4 pricks a day. Is very, very difficult to convince them in the first place. And even if you manage to convince them, I think they're not going to be very adherent or compliant with this. So you need to have a simplistic way forward where you can address both your fasting and prandial together, and if you can do that with a single prick, what better way to achieve? Now, earlier achievement and greater persistence of your glycemic goals, reduction in risk of side effects, and also delay, as we said, weight is one of the things that we look at, and if you're using higher doses of insulin, only insulin, that the weight burden increases, and this is mitigated by the GLP-1, and potential to delay underlying disease progression and especially organoprotective effects. So targets hepatic glucose overproduction by decreasing gluconeogenesis and reduces fasting blood sugar. This is what the basal does. And then glucose-dependent insulin release, reducing glucagon secretion, delayed gastric emptying, decreased prandial glucose excursion. These are the things that the GLP-1 does. So you have a powerful combination of both of them together. So IGLA-LIXI, and we have said this enough number of times, that if you're using a DPP, say a incretin-based approach, along with metformin or a basal insulin, and throw in SGLT2 inhibitor, which covers you for the kidney, you cover almost 7 out of 8 parameters. So IGLA-LIXI does a similar kind of a job because it's incretin-based therapy, which can cover you for almost 6 out of 8 pathophysiological defects that come with diabetes, including reducing hepatic glucose production, gluconeogenesis, reducing glucose uptake, decreasing lipolysis, increasing glucose-dependent insulin release, increasing satiety by both working at the level of your brain and reducing hunger, increasing satiety, but also locally by delaying the gastric emptying, which makes you fuller, feel fuller, and then you become feel more full with smaller quantities of meal. So global guideline recommendations for fixed ratio combination, you have many. The most recent one comes from the ADA, where they have allowed a fixed ratio combination of basal with a GLP-1. And then you have IDF endorsing the fixed dose combination. ADA to 2025 also has shown very robust evidences that you can use that as a first line. So IGLA-LIXI clinical evidences that they have generated are many. One is the SOLID-D study, which we are going to hear about in more details, and the LIXI-LAN-O study, SOLID-CGM study. Now we're moving away from long-term glycemic variability indexes like HbA1c. We're falling back on CGM. And those who are working with me in my clinic knows how frequently we do a CGM to understand the pattern. And, and it's hard evidence. You get the data within a couple of weeks. So if you're doing only a HbA1c based follow-up, you have to wait almost 3 months. Here, with a CGM-based approach, within a couple of weeks, you're seeing the trends. You're finding that the person is, achieving almost 90 or 100% time in range, and that assures you that when he comes back after 3 months, you'd be having a immaculate HbA1c control. So obviously, we are falling more and more on these kind of hard evidences that are generated from the CGM-based studies. So SOLID-D study was where IGLA-LIXI was used in type 2 diabetic patients who were suboptimally controlled on OADs, and SOLID-D trial compared IGLA-LIXI with IDEG-ASP. So co-formulation, which is IDEG-ASP, was compared to a basal GLP-1 fixed ratio combination. So there was non-inferiority in terms of the A1C reduction. That was the primary endpoint. And also IGLA-LIXI versus IDEG-ASP was compared in suboptimally controlled OADs, did go on to show that there was, as we said, non-inferiority and superiority over IDEG-ASP in A1C reduction. And if you look at the safety parameters as well, or the body weight, obviously, because you're using a GLP-1 along with the basal, the body weight reduction was there as compared to only insulin where the body weight increased. And then if you look at the total mean insulin dose, again, it was lower in the IGLA-LIXI arm versus the, the co-formulation arm. Lower incidences and events of hypoglycemia, and that's obvious. If you're using more insulin, especially the prandial component, causes more hypoglycemia. So that is mitigated because you're using a basal along with a GLP-1. So summary and conclusion of the SOLID-E study was that it was a 24-week head-to-head study conducted in Chinese type 2 diabetes patients suboptimally controlled on OADs, where IGLA-LIXI demonstrated, so this is another study of, we were talking about the IGLA-LIXI versus the co-formulation. Now we are going to talk about, another study which is coming up subsequently. This is the SOLI-CGM study. And as we were saying, that if you're doing a CGM-based approach, is faster, and you get to the glycemic endpoints, and you will see what is the time in range within a very short period of time. We don't have to wait for the long-term glycemic variability, constants like HbA1c. So one such study is this one, where we're looking at the change in the TIR, and we see that within 16 weeks, the time in range significantly improved in the IGLA-LIXI arm versus its comparator. And the secondary endpoints were glucose, total cardiovascular, the CV, or this is the variation coefficient of variation that we look at when we're interpreting the CGM, and also the mean daily interstitial glucose, maximum prandial glucose at the end of 4 hours, then time above range, and the participants achieving a CV of less than 36%. So in all of these endpoints, it was shown that IGLA-LIXI had fared better as compared to the comparator. So safety endpoints and hypoglycemia, again, there was no indicators that there were any safety signals. Any hypoglycemia was reduced. The daytime hypoglycemia event was also reduced. And the most important one is the nocturnal hypoglycemia, what we fear, because people are helpless while they're sleeping, and we want to reduce the nocturnal hypoglycemia as much as we can, and this was reduced in the IGLA-LIXI arm. So the conclusion was that SOLI-CGM study demonstrated that 16 weeks of treatment with IGLA-LIXI in people with type 2 diabetes and high A1C significantly improved the time in range and reduced time above range without causing any severe hypoglycemia. Now, to summarize, SOLID-E trial indicates IGLA-LIXI is a simple, well-tolerated treatment and better glycemic control, body weight benefits, and lower hypoglycemia event rates compared to IDEG-ASP, whereas the SOLI-CGM study indicates that people with type 2 diabetes suboptimally controlled with more than 2 OADs and GLP-1 RAs at the end of 16 weeks of treatment with IGLA-LIXI significantly improved their time in range and reduced the time above range without severe hypoglycemia. So the highlights are the complementary modes of action, as we said. Obviously, as we said, you require less units of insulin. You have a complementary mode because one is looking after fasting, the other one is looking after the prandials. You have the pleiotropic benefits that are coming out with the GLP-1s, and immaculate fasting and prandial controls, and once daily dosing, which was otherwise not possible if you're giving basal plus or basal bolus therapy, and addresses multiple pathophysiological defects. With this, thank you, and over to Chairperson, please.
I'm sure all of you would agree that it was an excellent oration, talk. Now it is open. If you have got any query, I'm sure Dr. Supratik would be very happy to take over.
So
Topic
I
is
see-
open for house.
I see many counselors here. So how many of you find it challenging to initiate injectable? Please raise your hand. How many of your patients would come to you straight away and be agreeable for an injectable? Please raise your hand. I think everybody faces a challenge. So it's how many of you find it challenging to convince 4 pricks a day at the initiation? So I think that's going to be a major concern. So the highlight of this particular talk is to have something that can give you an immaculate fasting and prandial cover with 1 prick, which was hitherto not possible, because in Indians we have 3 large meals and we need to address the prandial glucose surges with each meal. So if you're giving a co-formulation which covers you for only 1 large meal, the other 2 meals are unaddressed. So with this Igla-Lixi combination, you're ensuring that you're covering breakfast, lunch and dinner. So you're giving a much better prandial control as compared to only a co-formulation which covers you for just 1 meal. Plus the pleiotropic benefits that we were talking about. So I think that is something that we have to inculcate in our practice. When we use a basal insulin as a knee jerk, we have to think that in Indian context, the prandial state is very relevant and it's just not good enough to reach the target fasting. We need to address the prandial glucose simultaneously as well. Thank you.
So if nobody else has a question, may I ask one question, please?
Yeah.
Or just a thing. In this era of the newer GLP-1 receptor agonist, once a week prick, versus this, I mean, if at all I have to put in a GLP-1, would it rather not be one of the others with more robust data? What would be your take as to where are the patients where you would initiate this rather than, you know, giving
No,
it differently?
it's totally relevant. So I think we have once weekly GLP-1s with more robust cardiovascular data, for example, you know. So if we see that there is a background of cardiovascular history for that matter, or we want to, you know, give organoprotective benefits specifically, then you would want to have those kind of GLP-1s on board. But if it's only the glycemia that we are concerned about, I'm just happy with 1 prick a day. You know, like, so that's how we classify. Even the ADA has now clearly said, is it a glycemia-based approach or is it a complication-based approach? So we, as somebody catering primarily to those who are, although the line is becoming, you know, very ill-defined nowadays because, you know, it's just not good enough to address glycemia now. But obviously, our primary perspective remains in targeting glycemia at large. So if somebody is young, where the perspective is glycemia control, free from any comorbidities, I'm happy to use this ahead of a basal insulin, for example. But obviously, if I see that they're at high risk and they qualify for a once weekly GLP-1 therapy, that is the way forward.
Thank you so much. Thank you, Dr. Subramanian.
Thank you.
So our next speaker for the session is Dr. Iborua. Sir, and again, he needs no introduction. He's a very prominent endocrinologist of national repute. And he is associated with the Apollo Excel Care Hospitals, Guwahati, and he has multiple achievements to his credit. And without much ado, I will ask Manishda to please start his presentation.
Thank you, Arundhati, and thank you, chairpersons. Thank you, Supratik and your team for giving me this opportunity. I'll start by saying that what is power of 2? Power of 2 is actually 2. In mathematical world, power of 2 is 2 to the power 0, that is equal to 1. So in binary world, actually you have 2 numbers, 1 and 0. Binary world is that world by which does these computers and artificial intelligence they move. They only use 2 numbers, 1 and 0. So if you have to have 2 things in your mind, efficacy, that is glycemic control, and safety, that is no hypoglycemia or less hypoglycemia, you can think about this kind of preparation, which we have already discussed. And Dr. Supratik has nicely given you an idea in where you can use. I'll also more specifically talk about using it in certain populations, and I'll also tell you 2 things or 3 things about the cardiac safety of this molecule. Also not so glamorous as semaglutide, but still it has got some data which we should look upon. So I'll start with a very common garden type of case discussion, just for initiating the discussion. It's 57-year-old person, diabetic, for type 2 diabetes for the last 12 years, on metformin, SGLT2 inhibitor, and basal insulin, plus minus other OAD which has been changing, like buglibose or pioglitazone over the years. But nevertheless, even after basal insulination, 26 is not a bad dose for 57-year-old person. It's Indian population. HbA1c is 8.7 and BMI is 28, slightly, upper side, you can say, by Asian carvers obese. So you need to advance the therapy here. You need to address the HbA1c which is higher. At the same time, you cannot give some medications which can cause overtly increase body weight. So you have these options of using basal bolus insulin, which can cause weight gain and increase hypoglycemia. And a compliance issue will be there because the patient is not willing to use more than 1 injection. There is a problem. You can go for premixed co-formulations or premixed insulin twice a day. Again, another injection is there. And how about having efficacy with this particular medication using twice daily? And third is basal insulin plus GLP-1 receptor. So obviously, we are going to talk about the option of using basal insulin plus GLP-1 receptor analog. But of course, we are trying to compare it with a very commonly used form, preparation or the protocol, that is premix analog. So this Solimix study is a phase 3B randomized control trial which compared Igler Lixi twice daily versus biphasic expert 30. So it's a Soliqua versus Novomix, you can say in the commercial names. And in a population which were included in this trial were very typical population which you have, A1C more than 7.5 less than 10%, BMI more than 20 less than 40, people getting basal insulin at the dose of more than 20 and less than 50. Of course, when you more than 50, you cannot include because you need to have more interventions in terms of probably basal bolus. There is no option. So intermediate group was selected, and 2 arms. One arm received Igler Lixi, 440 odd patients, very powerful study, and another arm received biphasic expert twice daily. It's an open label randomized treatment trial because both products are already in the market, so you cannot, both products are different, so you cannot blind, you can make into one device and give it to 2 different groups. So usually these trials are open label, and it was a multinational trial. India was also India contributed substantially to this trial. So what was the result? So Igler Lixi showed superior HbA1c reduction. Does it sound a bit surprising? Yes, it was. It showed superior HbA1c reduction and weight benefit, which may not be that robust, but very interesting. Let us look at this. So look at the HbA1c reduction. With Igler Lixi, it is less. The reduction is 1.3%. With biphasic expert, it is 1.1% reduction. It achieved, firstly, the non-inferiority for which the trial was designed, and it also showed superiority. It was statistically significant. You can see the lower part of the text here. Superiority was achieved, where 0.2%, that is, p-value is less than 0.001. What about the weight benefit? The body weight benefit was very significant here because with biphasic expert, there was 1.2 kilogram body weight gain. With Igler Lixi, it is less, 0.7 kilogram less. It is a short duration study, but the quantum of decrease in body weight is not very significant. But when you're comparing with the other molecule which is being used for the same purpose, glycemic control, you can see that difference becomes 1.9 kilogram mean difference. And again, this was statistically significant. Now, what about a composite target achievements in various forms? Like you compare HbA1c reduction less than 7%, HbA1c reduction less than 7% without weight gain, another group, another composite endpoint, and then finally SbO2 reduction without weight gain and without hypoglycemia. This is what you dream of as a clinician. You want to reduce hyperglycemia. You do not want to give any hypoglycemia in this process, and you don't want any weight gain in the patient. So this final composite endpoint, starting with that, you can see 19.4% of population versus 7%. Again, for SbO2 reduction without weight gain, significantly better, almost more than 2 times. And SbO2 reduction less than 7% alone is 42% versus 31%. So Igler-Rixi showed superiority over biphasic aspart here. And what about the total insulin daily dose requirement? It was, biphasic aspart. Obviously, 2 insulins are combined, 22.9 and Igler-Rixi is 10.6. It's significantly less because you have another molecule to help your glycemic control. What about the incidence of hypoglycemia? So any hypoglycemia, 42.4 versus 31.2, that's less. And the ADL level 1 or level 2, level 2 is a severe hypoglycemia. Again, there also Igler-Rixi performed better, 6.3% versus 12.9%. What about the incidence of nocturnal hypoglycemia? And Dr. Supratik has alluded to that. Even for nocturnal hypoglycemia, for both ADL level 1 and ADL level 2, just more severe hypoglycemia. So where you can see that the relative odds reduction with Igler-Rixi versus biphasic aspart was 68% and 63%. So between bedtime and waking, and between 12 and 6 p.m. That's a specified time frame, and the another one is specified by the patient's waking hours, which could vary. But both ways it is practically very important because that's when most of the hypoglycemias may happen, and this was less. So hypoglycemia wise also, so the power of 2 in 1 is coming here, like better glycemic control, lesser hypoglycemia. And additionally, you are also getting the benefit of no significant weight gain. In fact, comparatively, you're actually on the lesser side while you continue this medication. So the summary of conclusion of Solemic study is a better glycemic control with weight benefit, less hypoglycemia, and fewer daily injections. Compared to 2 injections, you are only getting 1 injection. So usually this, Igler-Rixi is given 1 hour before breakfast because it covers most of the meals of the day. But in specific patient, you might change the timing, but it's almost always in 1 injection. And similar proportion of SAEs in both treatment group. So when you talk about any molecule used for controlling hyperglycemia, you now talk about the glycemic safety, because last 2 decades we have seen a lot of trials coming up with CV safety. In fact, both the components underwent cardiac safety trial, and we have all heard about the Origin trial, very big trial and very famous trial, which showed that basal insulin glargine is safe, or rather non-inferior to placebo in terms of incidence of cardiac events while using this molecule. So it is pretty long trial, almost 7 years, more than 7 years follow-up, so robust data, and cardiac safety, not efficacy, cardiac safety in terms of non-inferiority was established. So that can be extrapolated to all products where glargine is a component, and Soliqua is one product where glargine is a major component. What about the GLP-1 receptor analog part, that is lixisenatide? It was a pretty old trial, I guess 2014, and this study included participants newly diagnosed type 2, established or newly diagnosed type 2 diabetes with high risk of CVD. In fact, almost all of the patients already had a cardiac event. In terms of high risk, you can say it is even higher than liraglutide trial or empiric trial. Almost all of them had a very established cardiac event. So they took up this very risky, high risk population. And what they found was that lixisenatide compared to inert placebo was safe. It didn't increase any cardiac events in the population where it is used. So non-inferiority was established. So that way it has proven its cardiac safety. So both the component, glargine and lixisenatide, have proven their cardiac safety by these non-inferiority trials. So what about the dose titration and the device? So I'll just brief you about this. So for people who have not used it till now. So it actually in India it comes with this particular preparation where glargine and lexacentate comes in 2:1, and it's a 3 ml free fill pen. So 300 unit of glargine, like all insulin devices, you have the cartridges having 300 internal units. And when you have 300 unit, obviously 2:1, so you have 150 microgram of lexacentate. So you start with a 10 dose step, or rather you can say 10 unit of glargine, and you can go up to 40 dose step. This pen gives you an opportunity of using up to 40 dose steps of 40 unit of glargine and 20 microgram of lexacentate only. And we hope in future we have other devices where you can use higher dose of lexacentate. So that's how you go. And usually you titrate on the basis of fasting blood sugar, because you're targeting with glargine. So you're fasting it not in target, you can increase by 2 units or maybe 4 units if there is a hurry. So usually 2 units is one which I prefer, because that way you do not give the adverse impact of increasing GLP-1 receptor analog suddenly. So 2 units twice or thrice a week is a very good protocol to increase the dosing. So weekly dose adjustment is recommended by the manufacturer, but we can go up to at least 2 times a week, and you should do the self-monitoring plasma glucose fasting is a target. And so I will not go into the details of the entire thing. So this is how the pen, how it looks, and as I said, you can go up to 40 unit based on your titration. So this is one algorithm given by the manufacturers, like more than 100 and less than 140 increase by 2 unit. But your goal is your goal. Your patient is you have to customize, you have to personalize that goal. So generally speaking, if you target 100 to less than 140 of fasting and more than you increase by 2 unit, 80 to 100 being your target, there is no change. Less than 80, to reduce hypoglycemia, obviously you have to reduce by 2 units. But again, this has to be customized. But this is a general principle which you should follow while titrating the dose. The timing is, it should be injected subcutaneously once a day within 1 hour prior to any meal. So I prefer the breakfast meal, because breakfast, lunch, at least, and evening snacks, all 3 meals are covered by 1 injection. Missed dose, in case of a missed dose, inject Igler Lixi within an hour prior to the next meal. So if you miss in a breakfast time, you can inject in the lunch time, 1 hour prior to lunch time, even that is going to help. So elderly can be used in elderly patients. So for lexacentate, no dose adjustment is required, like GLP-1 receptor analog. Renal impairment, so creatinine clearance less than 30 is not recommended. Above that you can use. Pregnancy should not be used, not tried, not be used. Hepatic impairment can be used in patients with hepatic impairment. We all know that GLP-1 receptor analogs are peptides. They are broken down by proteases in your circulation. That's why they are in CLD or CKD, their metabolism doesn't suffer that much. But otherwise, because we do not have safety data for a particular molecule, we said do not use it below this particular EGFR, do not use it above this SILE group of cirrhosis, SILE A, B, C, a particular stage of cirrhosis. But otherwise, they are not metabolized by liver and kidney per se. They are metabolized by the proteases, and they are broken down to peptides which are not active pharmacologically. Hepatic impairment can be used in patients with hepatic impairment. For lexacentate, no dose adjustment is required in patients with hepatic impairment. That is what the manufacturer is also saying. So thank you very much. This is how I summarize, and we can have questions if you will.
Thank you, sir. It was a wonderful presentation as always. So now the house is open for discussion.
See, the idea of such presentations are that we should have maximum interactions. So, please come up with any query, and I'm sure our learner speaker would be very happy to answer. So the first, yes, So Dr. Supratik, can someone give him a mic, please? Hey, mic दो, तुम लोग बाहर आओ यार.
Yeah, yeah.
On है, yeah.
So I think fabulous presentation as always,
Thank you,
and I think the only concern that we have always as compared to initiating insulin is the GI adverse events that we face. And it's not for everyone. So many of them find it a breeze, they never complain of anything. As long as you're starting low and going slow and then you're up titrating gradually, I think most of them don't have an issue.
Yeah.
Now, how do you counsel for these GI side effects to somebody who has experienced insulin before? Say, for example, you're going from a co-formulation to a Igla Lixi, and then the person comes back and says that, Doctor Sahab, मेरा पहले तो कुछ नहीं हो रहा था, अभी देखिए problem हो रहा है.
Very good question.
So, what do I do in that scenario, and how do you counsel
Yeah,
the patient?
because there are a lot of prescriptions for GLP. I have got one handout made in English, as Hindi, Assamese and Bengali, because these are the 4 languages which are spoken by my patients. And we have got paragraphs written regarding how to take the meals and what to do, how to react when there is GI side effect. Even we prescribe, we write there, like over-the-counter drugs like, you know, antacid, or you can say prokinetics or proton pump inhibitors, SOS kind of thing. And only issue is that loose motion is tricky, because sometimes, not with this, but other GLPs, sometimes surprisingly loose motions happen, tirzepatide also. But there also we write in the prescription loperamide for loose motions. But just answering to, in the context of Igla Lixi, the first 100% I observed very carefully. I did a lot of counseling. Only one patient came up with GI side effect. And I think you have experienced the same thing. Could be because we are using relatively lower doses. When the higher dose, you know, that never came, although we expected it to come. Probably we are using a relatively low dose. That's why we are not seeing that kind of GI side, because lixisenatide is a short-acting GLP-1 receptor. It is supposed to cause more GI side effect than semaglutide or liraglutide. It did not, because probably we are using a low dose. That's why. Otherwise, short-acting are good for postprandial control, and that's why their action on gastric emptying is much more prominent than the longer-acting ones. So they should cause more side effect. But it didn't happen with lixisenatide. But I'm not going to give full credit to the molecule per se. It's probably because we are using a lower dose. But if it is so, probably same. I think we now should have a common handout for advices for people, patients using GLP, because it takes a lot of time in advising individually also. Some things should be written, and a brief discussion. I do it through my counselors, so thankfully I have a good team. But I think for an individual doctor it's difficult. But I think handouts can help.
So from your experience, sir, what is the maximum dose of Igla Lixi you have used, and after what dose would you like to change it to twice daily insulin?
I have used Igla Lixi 40 plus 20 unit glargine in many patients given at night. But I have not used Igla Lixi twice a day. Not Igla Lixi. So that's a different situation where I have to change my strategy. Looking at the SMPG, I may have to change to basal bolus also. Usually if my Igla Lixi plus glargine 20, as I said, which I do in many patients, fails, probably I have to go for basal bolus in that situation. Probably coming back to a premix insulin, premix insulin or co-formulation also may not help there, because many times the postprandials are going to be haywire. So probably next best option would be basal bolus. But you could use something in the dinner like repaglinite plus voglibose or a small dose of gliclazide. But this is individualized thing. I cannot say this is a guideline. So for the particular post-dinner rise, you may have to use that.
Okay, we'll take the last question, please.
See, per se, it is said from the pharmacokinetic and dynamic studies that CLD should not be a deterrent. But decompensate CLD, I think nobody will use GLP-1 receptor analog, because in any case the patient is bit terminal, and we should put more importance on nutrition and a little bit of glycemic control, which you need to do is with probably insulin. I probably will not personally prefer, although there is no direct contraindication to that. I mean, decompensate, you said advanced decompensate CLD. So I will not use there. Thank you, sir.
Thank you so much, Manish sir. For our next speaker, we have Dr. Demalya Sanyal. He's a senior endocrinologist, again of national repute, who is a professor in the Department of Endocrinology, KPC Medical College. He has had multiple publications, numerous awards, and he has been faculty in hundreds of conferences across the country. So, handing it over to you, Demalya.
Thank you. Thank you for the kind introduction. And after an excellent talk we had just listened to, a few observations from my side. I think I would absolutely agree that, we had the lixisenatide when it came for a brief period. That time we had some interest. We had, when we were using higher doses, we had significant GI side effects. But the beauty of this molecule is the combination, where the very small dose increments, absolutely, they are almost GI side effect free. And again, I would agree with Manas with regards to a lot of patients when we use this in the morning and 40 units, and we also use the basal insulin glargine at night also, and then we move on to a basal bolus regime. So these were my observations. So coming back to the topic which I have been allotted, the evidence continuum for second generation basal insulin. So we all know that the NPH insulin we still use it in pregnancy in a lot of our patients for pregnancy. And NPH insulin, as you can see, has a peak, and its duration of action doesn't cover 24 hours. Whereas glargine, the first generation, the glargine U100, had much lower peak, almost peakless, and 24-hour coverage, though its effect ebbed after about 18 hours. Then further we had improvement with the second generation basal insulin, which had less variability, a more prolonged 24-hour duration of action, and also because of almost peakless effect, you can see that there is minimal or risk of hypoglycemia, especially when we are using a basal insulin. Now most guidelines suggest first injectable probably a GLP, then we can also use basal insulin, and the first target is fasting glucose. And when we are titrating the fasting glucose, the highest risk is of nocturnal hypoglycemia. That is the major impediment for any glucose when we are using a basal insulin. So with that, if we can decrease the effect of nocturnal hypoglycemia, that would significantly address most of our concerns as well. So we have to balance between glycemic control and hypoglycemia, the main stumbling block being the nocturnal hypoglycemia. But the additional advantages with the second generation glargine U300 were, the safer titration, especially as we see that during the titration period, the risk of hypoglycemia and discontinuation is highest. So that is much less. Weight gain is, especially the snacking, is less. The dosage flexibility, because you can use plus minus 3 hours, and it has a prolonged duration of action for more than 24 hours, and both within day as well as between 2 days. You see a lot of patients would come up and say that, in spite of the same doses, we have a different glucose fasting reading in the morning. That is also significantly less, and that we see in our practice as well. And overall, the most important benefit is with regards to nocturnal hypoglycemia, especially in patients, those who have some hypoglycemia, especially nocturnal hypoglycemia on the first generation. This has to be changed to a second generation glargine. So you have host of studies from PKPD data to type 1, type 2 data, even the in-range study as well, comparing the RCT type 1 diabetes, which is almost gold standard, and the BRIGHT study, which compared head-on glargine U300 with degludec, and in patients who are insulin naive, and again, with regards to starting dose 10 units or 0.2 units, and what was found that, as we see in all treat to targets, the glucose lowering capability of all insulins are same. So the HbA1c reduction is similar, and the people who achieved A1C target are also similar. But what is important, especially during the titration phase, the 0 to 12 weeks, the titration phase, then the maintenance phase, especially the risk of hypoglycemia is highest during that period, especially anytime hypoglycemia was significantly reduced, 26 to 37%, but also there was a reduction in the event rate for nocturnal confirmed hypoglycemia. So this is a big benefit, especially with regards to lower nocturnal hypoglycemia risk with this molecule. So again, coming back to real world studies from India, which were conducted in 15 centers, which actually looked into adverse events and weight gain and satisfaction score, you see the glycemic control was significant. That is known, and especially in terms of fasting glucose control. But it was well tolerated with a low risk of hypoglycemia and high treatment satisfaction in insulin naive patients with type 2 diabetes. So low risk of hypoglycemia, and almost 99% continued the study. This is very important. Lot of our patients, when we are initiating them, they discontinue treatment. So in a real world scenario, patient continuing insulin is, I think, a big achievement. Again, we published last year with regards to the timing of glargine U300, whether it is given in the morning or at night, actually the safety and efficacy does it really matter? So this is something, because a lot of elderly patients, CKD, are fearful of nocturnal hypoglycemia, and so there for them, whether if they are given morning, whether the efficacy remains the same. So as we see, the A1C reduction, the fasting glucose reduction was similar. Again, there was no difference with regards to the HbA1c lowering and the percentage of subjects who achieve HbA1c target. And also in terms of hypoglycemia, both overall and nocturnal, there was no difference, though numerically nocturnal hypoglycemia was significantly lower, and overall, especially nocturnal hypoglycemia, was significantly lower with morning administration. So this is something very important, practical use, where we can use this molecule in the morning. Though it was not statistically significant, it was numerically less nocturnal hypoglycemia. So timing actually did not impact with regards to safety and efficacy, and the efficacy remains same. There was numerically lower nocturnal hypoglycemia, especially with morning dosing, and so we need to individualize in our patients. So especially in patients who are elderly, home care, where availability of people who would like to be injected, who have to be injected, would be difficult. So morning use also is effective and associated probably with lower risk of nocturnal hypoglycemia. Now moving into some segments where there is a higher risk of hypoglycemia, especially, ideally all patients who are using basal insulin should be using a second generation basal insulin, because same efficacy with lower risk of hypoglycemia, no doubt about it, but obviously it's more costly. So we generally need to select also people where it is almost mandatory if you are choosing a basal insulin. So in elderly patients who have a high risk of hypoglycemia and hypoglycemic unawareness. Second is during periods of fasting, which we just saw during the Ramadan period, where there is a risk of hypoglycemia is significantly increased. So basal insulin is very well suited for this population as well as in patients with renal impairment, where the neoglucogenesis by the kidney is decreased, as well as there is more retention of insulin. So you can see very well the addition trial, which analyzed the glargine U300 versus U100. So similar efficacy again, but a lower risk of nocturnal hypoglycemia in elderly adults. So in elderly adults, obviously this remains a choice, important choice, population subset, and especially more than 70 years, there was a significant lower risk of nocturnal 65 to 70 years. Again, the BRIGHT study, which head-on compared U300 with degludec, there the hypoglycemia was not different, but what was different was there was a better A1C reduction in the elderly population more than 70 years. So that is something important. Again, during fasting, again, pre-Ramadan, during Ramadan and post-Ramadan, mainly the hypoglycemia aspect was looked into, but there was also a significant A1C as well as fasting glucose reduction even during the Ramadan period, but it did not come at a cost of excess burden of hypoglycemia. So that's very important because there is no, it's almost peakless, and even if you administer during Ramadan at night, it covers 24 hours, and during the fasting period, we have several fasting occasions in different, across different religions across India. So that is something where we can use this molecule effectively as well as safely. Again, coming to the patients with renal impairment, the BRIGHT study again compared degludec with glargine U300. There was a better A1C lowering, though no difference in hypoglycemia pattern with regards to the patients who were renally impaired. Again, pregnancy, where it has been used, it was found to be safe with regards to outcomes in the pregnancy. So in summary, this is effective and it can be used as a once daily, less painful preparation with full 24-hour coverage with lower intraday as well as within day variability. Most important aspect is reduced risk of nocturnal hypoglycemia and overall hypoglycemia, as well as lower weight gain, flexible plus minus 3 hours dosing and improved quality of life, and especially during the high risk titration period, risk of hypoglycemia is less and can have effective and sustained control, especially in populations like high risk, like those who have had hypoglycemia, those who have had renal impairment or elderly population, or even with cardiovascular disease. This remains a very important choice. Thank you. Thank you for a patient hearing.
Once again, an excellent deliberation. We would invite few queries, few questions. If anyone has got, please. Switch on the mic.
Fantastic presentation, sir. Thank you so much. But I have my question to sir, who is in favor of using lixisenatide, and I recently had a very real world scenario of a lady.
Yeah, please.
So I had a real world scenario of a lady, moderately overweight, BMI of about 28, 29. She came with an HbA1c of 12.5. She is unfortunately a moderate alcoholic also. So I did prescribe her lixisenatide and this preparation. So and also SGLT2I and linagliptin, empagliflozin and linagliptin.
Why linagliptin?
Linagliptin because she was having some, just like that. I mean,
it's already you have given one from the incretin axis.
That's true.
So linagliptin, it doesn't harm.
Yeah.
But it should not help actually. We are giving supraphysiological dose of incretin hormones.
Yes.
So anyway.
So that way is the prescription correct? Because she was initially very, obstinate to taking insulin at all. She's the newly diagnosed diabetic, never has been prescribed any medicine.
So, when you say that A1C is 12%, obviously her fasting and postprandial are pretty high.
249 and 400.
Yeah, so the difference between fasting and postprandial also pretty high.
Yeah, right.
I think it has been also mentioned by Supratik earlier. You are justified because you are targeting both together. There is no harm in targeting. Only little concern is her alcoholic history, if
Yeah.
a lady having moderately heavy alcoholic intake, she could be at a high risk of pancreatitis. This is again another GLP-1 risk channel.
Against
Yeah,
her.
so then the whole world is going to ask you why you have chosen out of all these things in the armamentarium, why you have chosen this one only. So there you have to probably counsel the patient not to drink, and you have to assess the risk of pancreatitis, take the
Yeah,
history
that I have done,
carefully.
I have done.
Yeah,
Her
then I
amyloid-
think you're justified. Only issue is that probably linagliptin may not
Can be
have been
avoided.
added
Can be
into
avoided.
this.
Thank you, sir.
Thank you. So with this, we will close this session.
Thank you.
Thank you so much. Thank you to all the speakers.
Good afternoon. We would skip one session and go to the next session, that is clinical practice integration. Dr. A.K. Singh is on the other room giving a talk. So I would like to invite the chairperson, Dr. Rupam Chaudhary, who is a consultant diabetologist at Apollo Clinic, Dispur and Guwahati, and Dr. Debapriya Bakshi, who is consultant diabetologist, New Life Diabetes Clinic, Hooghly. Over to you, sir.
Good afternoon, all. So, the next session is on clinical practice integration, and we also have a moderator, Dr. Sandeep Tuck. If he is available here, may I request? Yeah, Dr. Sandeep, please.
Good afternoon, everybody. So basically, in this session, there would be three very top-class speakers talking about tirzepatide. What would be the real-life experience of the tirzepatide, how to use it, and what are the basically various pitfalls and what are the pearls they would be advising to you people. First speaker, I think, is Dr. Vipul Chawda. He would be talking about the from RCT to real world evidences. Dr. Vipul, please. Yes. Yeah.
So good afternoon all. Thank you so much, Chairperson Dr. Sandeep sir, for kind introduction. Let us talk about an evidence that is from randomized control trial to a real world evidences. This talk is important because it is not about whether tirzepatide will work in a patient or not, but it is about my clinic, my patient, how the data from randomized control trial is translated in real world also, that we will see in next blue slide. So when tirzepatide was launched in our country, we all were very happy that there is some molecule that is having disease modifying efficacy, which can lose more than 20% of weight. But we have to understand and we have to learn that whether this molecule is applicable for our patient or not, and we were waiting for real world data about that. So let's understand this thing. This is my disclosure. And when we compare, yes, randomized control trials are gold standard, and rightly they are, because they are done in precise clinical setup. We have predefined pro forma, we have principal investigator who is supervising it, and all the patients are selected with inclusion-exclusion criteria. The disease, the duration of the therapy is predefined, and also we observe all the minute details. But it is not guaranteed that in real world such patient selection will happen. In real world the patient diversity will be more, there will be a real comorbidities in the patient, and adherence is a very important issue when we are talking about chronic therapy. Yes, in real world evidence, we can see that the populations are real, the comorbidities are real, the adherence, whether people or people with obesity follow it or not, and we can also find out some rare side effects. So real world data are equally important as randomized control trial. They both are not competitive to each other, but they are complementary to each other. The real world data can be from electronic medical record, from hospital data, from pharmacy data, or from patient registry, but we have to form a proper methodology to have proper outcome from that. Also, there are two kind of randomized control trial, parallel RCT as well as crossover RCT. I am not going into the detail, but I need to tell that randomized control trial are for efficacy of the molecule, while the real world evidence are for effectiveness of that molecule. So real world evidence are equally important. If we consider that randomized control trial are part 1 of Durandar, then it is incomplete without real world evidence, which is a part 2, where we have to eliminate all other risk factors. So both are equally important. When tirzepatide was launched in our country, we were very happy with the data of SURMOUNT and SURPASS, but now we also have data after 1 year about the real world efficacy, how patients are reacting, how we are up titrating the dose, and how the adherence is there. So let's first understand about randomized control trial on tirzepatide, how the effect is on weight loss as well as on glycemic outcome. This is SURMOUNT 1, in which the patient with obesity were studied with the effect of tirzepatide, and more than 2,539 patients were studied in this protocol. The study was compared with a placebo. So we are very happy to find that more than 20% of weight loss was possible with pharmacotherapy, and tirzepatide 15 milligram was able to reduce the weight about 20.9% in person with obesity. But the more important thing was that the 5% weight loss is clinically very significant. It has a disease modifying effect, and more than 90% of the patients who were on 5 milligram tirzepatide were losing more than 90% of the weight. Yes, there were side effects, but all side effects are mild to moderate, mostly GI related, and there are some serious adverse effects, but the number of the adverse effects which were severe are equal to the placebo. Let's talk about SURMOUNT 5. Here the things become very interesting, because now we are moving from placebo to semaglutide as a comparator with tirzepatide, and the number of patients were more than 700. What we find in the SURMOUNT 5? We found that semaglutide has a 13.7% weight loss, while tirzepatide again has a more than 20% of the weight loss. And again, there are 2.8% higher chances of reduction of HbA1c and weight reduction with tirzepatide as compared to semaglutide. Again, side effect profile were similar with semaglutide as well as tirzepatide, and also there were slight injection site reaction ratio more with tirzepatide as compared to semaglutide. Talking about diabetic population with obesity in SURPASS trial, there were 870 patients, and it was again compared with the semaglutide 1 milligram and tirzepatide maximum tolerable dose. Now in this also, even 5 milligram of tirzepatide has more weight reduction as compared to semaglutide 1 milligram, and also we can see the HbA1c reduction was higher with 5, 10 and 15 milligram tirzepatide as compared to 1 milligram of semaglutide. Again, side effect profile were only gastrointestinal, they were mild to moderate, nausea, diarrhea and vomiting. Hypoglycemia were minimal, and serious side effects were equal in the both group. So the data was very clear from randomized control trial that these molecules are very promising in obese as well as type 2 diabetic with obesity patient. But what is the whether this data is translated in real world practice or not, let's see from further few slides. This is the first study that compared a semaglutide versus tirzepatide for weight loss in adult with overweight and obesity. More than 18,000 patients were enrolled, and at 3 months, at 6 months and even at 12 months, tirzepatide has superiority in reduction of weight as compared to semaglutide. Then also when we use this molecule in a resource constrained setting, again we find that the total weight loss was 11.9%. Though the patient number were very less in this study, only 25 patients were enrolled, but also people who were losing more than 5% weight were 100%, and that means this molecule has disease modifying effect with people with obesity as well as for hypertension. Again, some real world data for the efficacy of tirzepatide among people without evidence of type 2 diabetes from United States study, and here also we can see that HbA1c reduction, BMI reduction and and weight reduction were superior with the use of tirzepatide. For the effect in type 2 diabetes, we can see that HbA1c reduction from baseline 7.79 to 6.77 after the usage of 10.4 months, and baseline weight was 113, that reduced after 10 months to 104. So more than 9 kg weight was lost in this real world evidence also. This is a paper from Dr. Chawla and Dr. Salini Jaggi, which is a first Indian real world experience for the efficacy and safety of tirzepatide improving the metabolic parameters in type 2 diabetes. It was 6-month observational study, and we can see that 10.9% BMI was reduced, HbA1c dropped 1.48%, and waist circumference is also reduced by 8.15%. So this molecule, the real world data is also showing that molecule is equally effective in Indian population in real world setting as compared to randomized control trial. This data is also showing that tirzepatide has good adherence as compared to semaglutide. Though in all study that randomized control trial we found that if side effect profile were similar, but in real world we found that more than 55% of the patient has better adherence with tirzepatide and better persistence of therapy with the tirzepatide. So in the end, I would say that in my patient, in my clinic, the tirzepatide is effective, which was promised in randomized controlled trial, and I can see that in real world evidence also with the diverse population, with people having real comorbidities, the people with having real complication, still they are having good adherence, good weight reduction, good HbA1c reduction, as well as good weight circumference reduction. So in real world clinical practice, tirzepatide was associated with substantial weight reduction and glycemic control in individuals who are obese with or without type 2 diabetes. Thank you.
Thank you, Dr. Vipul. I think we will take questions in the end. Okay. Our next speaker is Dr. Dhruvi, and she would be talking about Indian perspective as far as the people with obesity are concerned and use of this molecule tirzepatide. Dr. Dhruvi, please.
Thank you, sir. It's indeed always an honor when you're there in my session. Thank you. First of all, congratulations to the entire team of EMOCON for such a wonderful first day, and we've had so much of fun. And I am going to take you through a case which is from our own clinical setup. When we use tirzepatide, okay, I think I'll use this. ये चलेगा? आप on करके दो ना?
You can take this.
All right, thank you. Thank you. So for all the audiences sitting here, how many of you have used tirzepatide? 1. Vipul sir? 2. The audience is in the back. No exposure yet. So let me tell you some basic about tirzepatide. Tirzepatide is a twin-cretin molecule. It has a GLP plus a GIP. And because of this dual component, it is targeting the GLP defect in the body whenever somebody has type 2 diabetes or whenever somebody has obesity. So that leptin insensitivity and the ghrelin inaction that happens in people with obesity, jiski wajah se they have cravings, they have increased hunger, reduced satiety. So this molecule acts on the dual pathway of GLP and GIP and enhances the incretin impact, and thereby taking care of the sugars, thereby taking care of the cravings. Now, when the trials were run, now this is a supported lecture, so that's my first disclaimer. And before I take you through that obesity, case, Dr. Manisha is going to talk about her real-world scenario. Dr. Vipul just presented the evidence behind the molecule and how effective it is. So in terms of an HbA1c control, the molecule has shown that it will give you 1 to 1.8% of HbA1c control. So for example, somebody having a 10% HbA1c, if you are giving this molecule for 3 months, you can expect to have a HbA1c reduction of 1 to 1.8%. In terms of obesity, this is approved for type 2 diabetes and obesity, 2 main indications of tirzepatide in India right now. And that is what we are all discussing. When given to a person with obesity but without type 2 diabetes, you can get around 20 to 25% of weight loss, which is a big number. So say for example, a person with 100 kgs of weight, a BMI of say 30 and above, that is the guidelines, that 30 and above without comorbidity, you can prescribe the molecule. So if you are able to prescribe this for a person of 100 kgs, you can expect a weight loss of 20 to 25 kgs in the period of 6 months and plus. So that is what I'm going to show you all a case about. कहीं तो चल जाए ये slide changer is थोड़ा सा not working. All right, so that's my disclaimer that this is an Eli Lilly supported symposium, and thank you Eli Lilly for supporting EMOCON also. So this is my case, a 46-year-old person who had come to our institute, and that person had come with the fact that I am obese, I am a very working person, my lifestyle is sedentary, I am already doing some sort of a diet intervention, but I am not able to reduce weight. You tell me what further should I be doing. So in an ideal scenario, what we prescribe is आप exercise करो, आप खाने में और भी modifications करो, and we do an entire history and a metabolic parameter to examine this person with obesity. Because we want to know whether the person is diabetic, whether the person has any cardiovascular disorder, and 46 is not a very big age, right? 46 means that person is still in the prime of his life. He still has so many things to do. His weight was 146 kg. Huge, agreed to that. I thought, a lot of us needed tea and coffee, and that is why I thought we'll do an interactive sort of a session. So this person, jiska weight 146 kg hai, he did have dyspnea on exertion. Again, very logical. 146 kg wale person ko on walking, he will have some amount of dyspnea. He will have fatigue, of course. Thoda sa from one hall to another also that person will have fatigue. He will have daytime sleepiness. Now, these are all also symptoms of obstructive sleep apnea, and somebody else in the other hall is also presenting on this. His BMI came to 44. He did not have any other comorbidities which were priorly existing. He did have a history of snoring, but he had hypertension and dyslipidemia which existed, and for that let us see what tablets he was taking. His height is 181 centimeters and his blood pressure was 130/90. Are you happy with this blood pressure in a normal clinical scenario? This side? Okay? Okay. Those people are nodding no. This side? Okay, not okay with 130/90? Not okay. Okay. That back side? Okay, okay-ish. So we are a mixed crowd then. Some people are okay with it, some people are not okay. So I also would not actively up titrate his hypertension medicine. I would say that the lifestyle modification and the weight reduction is going to help you. So let's look at his other parameters. We got his fasting done, PPBS done, again we got a lipid profile done, A1C and everything. So if you look at all of those parameters, they are not bad. He was not a type 2 diabetic person. His A1C is coming 5.3 only. Fasting PPBS also okay, 114 fasting, PPBS 132. LDL 126, good or bad? People in the behind? Bad. So LDL you can take as low as possible, and that's what the guidelines are saying. HDL 36, good or bad? Bad, of course. We all agree and we are all in the same zone that it is bad. It could be increased. Triglyceride 234, good, bad? Bad, of course. So then we are all on the same page that this person requires some active intervention in terms of active dyslipidemia management, active blood pressure management, and also obesity management. So that's what we did. We counseled him for tirzepatide. That tirzepatide is going to give you advantage in terms of weight, and that weight loss is going to give you benefit in terms of the dyslipidemia as well as the hypertension. Of course, the one thing that we should not forget is lifestyle modification. You have to give a proper nutrition, you have to give a proper diet chart, you have to give proper exercises. Even to that fellow who is having dyspnea on exertion or fatigue, get a proper cardiovascular workup done. If everything is normal, he or she at 46 years of age should start very step by step. That you start with mild exercises and then gradually up titrate it. Counsel that there will be some GI upset. Whenever you are taking the first dose or whenever we will increase your dose of the injectable, you will get some nausea, some vomiting. There will be reduction in your appetite. There will be reduction in the food that you are taking. So please make sure that if there is any trouble, come back to me or come back to my team. So we have a team of a nutritionist, a counselor, and a physiotherapist. So they follow up with the patient at every 2 weeks time period. So that is after every 2 doses. What our target was, we also teach them that this is a realistic target, that you should be able to achieve a certain X number of weight loss, or your symptoms would be alleviated, or you'll start to feel a little better after so many doses. So we write that down. For this person, we started by saying that you will get, say, around approximation of 20 kgs of weight loss in a period of one year. You always give them realistic target. What if this person is unresponsive? So always make sure that you're giving them very, very realistic target, and also say that it is not just cosmetic intervention that we are doing. We are doing a metabolic intervention. We want you entirely better and not just for the sake of your obesity and numbers. So in November, we initiated him with 2.5 milligram of tirzepatide. The initial dose of tirzepatide is 2.5 milligram, and the guidelines are very clear that up titrate it after every 4 weeks. So it is 2.5, give the same dose for 4 weeks, then make it 5, wait for 4 weeks, give 4 doses. After that, increase the dose to 7.5, give it for 4 weeks, increase the dose next to 10 milligram, wait for 4 weeks, and then finally in the month of March, we were able to escalate the dose to 12.5. Other than that, we had also put him on statin, telmisartan, propranolol, which was going on, and since he on and off had some GI side effects, he was on omeprazole and domperidone. All of these were helping him with not having any nausea and vomiting. What happened in all of these months from November till March? Look at the up titration time and look at how his weight loss has been happening. Look at it in terms of BMI and weight. Just appreciate the down trend of the graph. We started at 146. In March, we are standing at 124.2. So just within this period of time, which is November, December, January, February, March, so that is 6 months, we are able to achieve the target which we gave and set for that person for a year, which is a very good number and a very significant number for that. So this is the baseline parameters, and this is, I think we should have changed that from August to March. His fasting has improved, his PPBS has improved, his A1C has improved, VLDL of course has improved. The most striking point is LDL has improved and triglyceride has improved. HDL has not improved so much, which should have, had that person done a very good exercise regime. To increase HDL, exercise is one of the most beneficial component. So let me just summarize the results that we got. From a weight of 146, we reached to 124. From a BMI of 44.6, we reached to a BMI of 37.9. From a triglyceride of 234, we reached to a triglyceride of 148. A very good significant achievement. What should we be doing as a follow-up? He is already on 12.5. I would still up titrate his dose to 15 milligram whenever the escalation time comes, which is in the month of April now. I will still continue with telmisartan, propranolol, ask him to monitor his blood pressures, ambulatory blood pressure monitoring at home. I will still ask him to intensify his lifestyle more. I will ask him to exercise more, and we will reassess his lipid profile in the coming time period. So now we were able to, this is a very, very real world case. We were able to get almost 15% weight loss over a duration of 4-5 months. BMI improved, of course, and that is what our target was. Our indication was obesity over here. Combining this twincretin with lifestyle modification is giving us one of the best results for this person with obesity. And yes, I think I completed on time with that. Thank you, sir, again.
Thank you. Thank you for completing in time. Excellent talk. As usual, we'll take questions in the last. Our next speaker is Dr. Manisha Gupta. She is from Kanpur, and she would be talking about use of tirzepatide in a patients with type 2 diabetes. Dr. Manisha, please.
Thank you, Dhruvi and Vipul, for setting this stage for me. Wonderful case presentation by Dr. Dhruvi. I think it would have given a clear clinical implications. How do you use this molecule in your clinical practice? I will be talking about diabetes and how do you use this molecule in case of diabetes patient. So we usually come across in our country like lot of patients that India is the capital of diabetes, and how do you use this We have been using this since the time it has been launched, and have this entire symposium has been sponsored by Lily, and thank you Lily and EMOCON for having me here. So this is a patient we usually see, like we have all age group of patients who come to us in our practice of, they might be 60, 40, I see very young patients, young, obese, diagnosed at the age of 22, 16, like that. So this is, though this molecule has not been recommended under 18, it should be given more than 18, and the data, we need to study further to use this molecule under 18 years of age, but we are definitely seeing patients, especially child with obesity. And this type 2 diabetes, he's a 60-year-old male, type 2, he is on OHAs. Initially we try with metformin and then sulfonylureas, DPP-4. We have number of molecules which we can use and enhance the glycemic control in our patients. But this is, as like this patient is already on basal insulin but not able to control. There might be various reasons, like his lifestyle, stress, his diet is not appropriate, or is not taking care of himself, or the mental health is not supporting. And because this is diabetes is a chronic disorder, and mental health really have a major impact on patients with management of diabetes. So here is a case of Mr. Kumar. His baseline HbA1c is 8.3 and the ideal recommendation is 6.5 to 7. Fasting is 150, postprandial 238, blood pressure 140/86, weight around 86 kgs. Mean duration of diabetes is 12 years. That's a pretty long diabetes, and in that way the beta cells has been exhausted with sulfonylureas or multiple molecules. So he has been given insulin in that case. Metformin is on 500 sustained release BD dose, DEPA 10 OD dose, glimepiride 2 mg BD, and basal insulin 38. Along with glimepiride and basal insulin, which comes a very deadly combination because it might cause a lot of hypoglycemic events. Along with that, he has comorbidities of dyslipidemia, hypertension, and osteoarthritis, though he's weighing more. Like, I come from Kanpur, and there are a lot of doctors, especially orthopedicians, who are dealing with osteoarthritis, who tell their patients, because this is the age when they go for knee transplant. So they themselves prescribing this molecule in terms of once they are able to reduce weight, when the surgery, the knee transplant has been done, it will be very easy for them to get back to their normal life. So this gentleman is already on basal insulin 38 with HbA1c of 8.3. So why this is clinically important? He has a very long duration of diabetes. He already has comorbidities of hypertension and dyslipidemia with osteoarthritis. And because of this, initially in those days when patients were not very motivated to exercise, so this scenario has been still on. So 60-year-old gentleman might not be very physically active. He has also developed insulin resistance. So how much ever exogenous insulin you're giving to his body is not able to work well due to, along with osteoarthritis. So he is not able to do a lot of physical activity. Along with glimepiride and basal insulin, his risk of hypoglycemia, and with that he is gaining further weight. If uncontrolled, high risk of myocardial infarction, like you can have number of complications like micro and macrovascular complications once the sugar goes haywire. So you are very prone for nephropathy, neuropathy, retinopathy, plus along with macrovascular complication. You name the organ and diabetes impact that. It does not leave any organ in the body. So what I have written a note in my clinic कि डायबिटीज़ का इलाज बहुत महंगा नहीं होता, महंगा उसकी कॉम्प्लिकेशंस होते हैं. So you need to be vigilant from day one of the diagnosis. Do not take it very lightly. Otherwise, you will be going doctors to doctors. We will take a back seat, and then all nephrologists and ophthalmologists will come in front. So we have multiple medicines available. In case this patient is there, we can definitely increase the basal dose just to take care of his glycemic control. We can also put him on basal bolus, we can put him on 30-70 and multiple options. So why not getting to this molecule? Because he has osteoarthritis. As Dr. Vipul has already mentioned, various trial has been done, Surpass, Surmount, Flow trial has been done for improvement of kidney functions. And it will definitely have an impact. I have done this in my clinical practice and received a lot of good results with this. In fact, I have started with my patients who were diabetic. They came to pre-diabetics, almost diabetes has gone into remission. And why this molecule? Just to enhance the proper whatever exogenous insulin you are giving to your patient, it really makes it work. You can definitely reduce the dose of insulin what you are giving to your patients along with the reduction in sulfonylurea dose. HbA1c reduction has been observed minus 2.3% to 2.5%. I have observed more HbA1c reduction with multiple. As you up titrate the dose of this molecule, you can have a better HbA1c reduction. A significant great percentage of patients receiving 5, 10, 15 tirzepatide versus placebo met the HbA1c target less than 10 at the week of 40. Also achieved significant body weight reduction. Obviously this molecule has been given for the same. There's a definitely improvement in, as you improve the weight, their appetite has been controlled, their satiety has been done, has been taken care of. But before prescribing to this molecule, you need to make a certain changes with the already existing molecules, like you should not give this molecule with DPP-4 inhibitors. If the patient is on this molecule, you have to stop it. Along with, you need to reduce the dose of insulin and sulfonylurea because the patient has the tendency to go into hypoglycemic events. Plus, dapagliflozin can be given along with this because with DAPA, this really works wonder as not 1 + 1 or 2, it becomes like 1 + 1, 11 is like that. And significantly, definitely improve in fasting and lipid profile as well, suggesting amelioration of overall cardiometabolic risk. So with this patient, the overall journey, the time of diagnosis from 2020, his HbA1c used to be 9.6 until there 2025 is still struggling to maintain it from 9.6 to 9.5 and currently on 8.3. Whereas if you talk about the weight of this patient has been continuously like 90, 80s like that. And from 77 has gone to 86 till date. So he's been continuously going on increasing weight along with HbA1c, which is not controlled. So this adds to another stress that whatever he has been doing in these many years, the effect has not been visible. So with these patients, the treatment plan would be just to bring the HbA1c less than 7, you should initiate with 2.5 and slowly up titrate to 5. Do not hurry. This is what I do. If the patient is doing very well on 5 mg and want to stick to that, you can stick and you can wait for another month and then you can up titrate to 7.5 or 10. If the patient is really doing good with 7.5, continue with that. After 4 weeks, it's upon clinician choice whether how the clinician wants to escalate the dose as per the patient's need. Recommended maintenance doses are 5, 10, 15 per week injection. So all the medication needs to be adjusted. As I said, the insulin dose and sulfonylurea needs to be proper adjusted once you are prescribing this molecule. Lifestyle intervention and diet, exercise has no alternate. Iska koi vikalp nahi hai. So this has to be mandatorily taken a point, like you have to change your diet and lifestyle intervention. So this is very important. So they need to be physically active. If they're not able to walk for 40 minutes a day, you give them choices. If you're not walking in the morning, walk in the night or after dinner or after every meal 10 minutes. So that makes a 30 minutes. So you need to give alternatives to your patient in terms of their management or lifestyle interventions. So with this molecule, this was initiated. His weight was from 86 to 77 from month 1 to month 6. And HbA1c, which was 8.3, it came down to 6.4. And this also gives a sense of well-being, enhances the quality of life in your patients. Definitely his lab parameters were also improved from like 6.5, the baseline was 8.3, fasting 70 to 99 to 150. His triglyceride came down to less than 150 and LDL less than 100, which definitely needs proper addressing. Blood pressure could also maintain. This glimepiride dose was reduced, and glargine, obviously, once your weight is lost, you need to put down the insulin dose as well. So just to summarize, HbA1c was improved from 8.5 to 6.4, weight 86 to 77, triglyceride 150 to 131, blood pressure 148/86 to 134/82. So this is how, with the molecule, when you intervene, this is the results you get to see in your clinical practice. Make sure you should not give this molecule with the patients having pancreatitis, planning pregnancy, or pregnant. This molecule needs to be stopped if the patient is planning pregnancy 3 months at least prior. So reproductive age group, be little cautious, and pancreatitis history, medullary carcinoma of thyroid, GB stones, though it is not contraindicated in GB stone, but you should be little cautious in this regard. So just to conclude, patient could achieve HbA1c in these many months, like 6 months from 8.3 to 6.4, improvement in lipid, improvement in diet, satiety. Moreover, we are not talking about fasting peep in HbA1c, we are talking about quality of life also, and improve in glycemic variability. Thank you for patient hearing.
Thank you, Dr. Manisha. Another excellent talk on the tirzepatide, 110. So now we are open for the questions. We have all 3 speakers here. Anybody from the audience? Yeah, please. We want more questions from the younger people. Yeah, please come on. You can come here, yeah.
Hello, good afternoon everyone. Thanks to all the respected speakers for such practical examples on tirzepatide use. I had one doubt that we talked about the absolute goal, like in terms of the weight loss, the percentage of weight loss. But is there any clinical target in terms of the rate of weight loss when we are monitoring the patient monthly? So is there any rate of reduction that we are targeting? And based on that, we are deciding on further escalation that ma'am told beyond 5 mg, we may not always escalate. So is it mandatory to escalate all the time, or is it there is a goal of a rate of reduction based on which?
That's a very interesting question. Yeah, Dr.
Actually, it is very interesting, and a lot of us kind of do feel scared when there is a rapid weight loss happening. In a real world practice, it is something that we should be discussing off the stage, but in a real world practice, we generally do not go very disciplinized or systematically. Some people may not require higher doses. You can stop at 5 milligram and then continue them on 5 milligram if they are able to maintain the weight loss that they are comfortable at without comorbidities, and we are comfortable at with good metabolic control.
So basically, as a clinician, my goal will be to also look at the other blood parameters, whether if it is decreasing, then I can wait further.
You can
and not going for aggressive weight reduction.
Absolutely.
And what about the complications of rapid weight loss, like the more lithogenicity of the bile and risk of gallstone formations?
You have to monitor all of those.
Okay.
If you are suspecting that in a patient, then you should monitor those. It does not happen with everybody. So monitoring is something that we recommend.
Okay, thank you. Thank you.
Yeah, and most of the patients, 7.5 to 10 milligram, they basically settles on that. But some patients you need to upgrade to further 12.5 or 15. Any other question, please, from the audience? So, yeah, from the chairpersons, yeah.
So just a couple of things, anybody can intervene. One is, are you monitoring for retinopathy before starting GLP-1? First thing, for diabetic patients as well as non-diabetic patients who are morbidly obese.
So for non-diabetic patient, in real world actually we do not go for retinopathy screening. But in diabetic patient, we are very cautious that we do ultrasound for gallstone or any chronic pancreatitis kind of thing which is not symptomatic at present. And also we see for retinopathy, if it is acute proliferative, we are holding the molecule for a while until the ophthalmologist gives the consent. Otherwise, we can start the therapy.
I think in most of the cases, if diabetes is less than 3 years, even you not need to go for the screening of the retinopathy. Early diabetes, obesity, you don't need to. But recommendation of ultrasound is as concerned, it's not a recommendation. People are cautious about it, and particularly patient is having a significant GI side effects. You can just go for the GI ultrasound and see if patient is having gallstone or something, and then you can be more cautious.
The question is to Dhruvi. What is the percentage of lean mass loss in your case?
In this particular case, it is still 5%. Yes, we do a body composition analysis also. So in this case, it was 5 to 7% from my memory.
So
any
recommendations, advice to that patient
as
to
low as
retain
possible. But when patients don't exercise, they are not good with their protein intake. We have seen muscle mass loss of almost 8%, 10% and more.
So that is something we
I'll
should
tell you,
be.
but that is a very, very interesting argument and debate that we've seen everywhere. Even in the muscles, you do have the adiposity. So whenever there is weight loss, you are bound to lose 5 to 10% of muscle mass. And that has been considered as an okay or acceptable muscle loss. But that is why we always recommend a good protein supplementation. We always recommend a good exercise regime.
You need a resistance exercise, basically. You need a resistance exercise.
Muscular strengthening exercise.
Especially in the case of Dr. Manisha, the elderly patient. In that patient, if we lost the lean mass, then there is a sarcopenia. Already elderly are sarcopenic. So in those cases, again, the chance of fall increases. So I think the lean mass weight should be taken into account, especially in elderly.
I will clarify one simple thing. Whatever method you use to lose weight, even diet, lifestyle, you are going to lose lean mass, so-called lean mass. And it is almost similar, you are losing it with a drug or you are losing it with a diet. Lean mass loss is almost similar. Important thing what Dhruvi mentioned, high protein intake, resistance exercise. That can improve the strength and overall body composition even with the loss of lean mass. Overall body composition in these patients improve. Fat percentage goes down and muscle percentage, even if remain, go little bit down, overall body composition improves.
And I'll tell you what, sometimes we are so scared of that sarcopenia, even in older patients, that we forget that the visceral adiposity is also something that the molecules are targeting, be it any of the GLP molecules, even the twin cretins. So keeping in mind that losing of that visceral adiposity is important in older people, in people without diabetes. So at least a good 5 to 10% of clinical weight loss has to be targeted again through any of the modalities, be it with exercise, be it with lifestyle modification and nutrition, or with pharmacotherapy. So there aren't
there is no age limit basically, but you have to choose your patient. And
yeah, true. As SGLT2, we say frail patients, somebody who's 70 plus or 75 plus. There is no guideline for this, but then again, as sir has mentioned,
less than 18, not recommended. So that's the age limit. Yeah.
So Dhruvi, another question that comes to my mind, and I think you will clear it. Many people talk about mental health, issues of mental health, and people may have issues with that. Do you come across any newer studies which suggest something?
So, not with tirzepatide, we haven't seen any depression or any anxiety issues, and I'm not aware of any new research along with tirzepatide for mental health.
Yeah, in fact, most of the studies now are coming with the GLP and GLP-1 analogs. They are positive. They are basically positive.
My patient,
yeah,
who could not respond. They were non-responder with 15 mg. So I was targeting from 3 digit to 2 double digit. Who were non-responder, they had this depression, and they used to come and tell
No,
me, ma'am.
that,
that was the only
that
thing,
depression is
otherwise
because
none.
of their pocket is going lighter and lighter, and they are not losing weight. So obviously,
That was the only thing I've come across.
non-responder patient, if is on this medication for 6 months, first 3 months you can judge patient is responder or non-responder. And if patient is non-responder in first 3 months, no significant weight loss, there is no point in carrying on. Because there are genetic variations, I think.
Yeah.
The tolerability regarding the side effects.
So not all patients can, tolerate the higher dosages. This patient was able to. But there are more than, I'll tell you, 30 to 40% of the patients who are not able to tolerate those higher doses. Always counsel them. And there is going to be some GI side effects on the first dose escalation. By the time they are in the 5th day, 6th day, and the second dose, they're, say, nausea, vomiting, some amount of flatulence, and diarrhea also. That also reduces by the time of the second escalated dose administration.
It is even the same on the 12.5 milligram dose, also the same.
For 12.5, sir, also it is same, and for some people from 2.5 to 5 also it is the same.
Whenever you are escalating the doses, there are chances of some little bit of side effects, yeah, definitely. But usually after 10, most of these people are well adjusted. Yeah, I think we can conclude the session. Thank you. Thank you, everybody. Thank you, chairpersons.
Thank you.
Thank you, sir. So we'll be moving on to the next session of today, which was actually left behind. So we'll be talking on the rethinking type 2 diabetes. The chairpersons are Dr. Malay Parekh and Rupak Chatterjee. They're, I think, in the other hall. So I'd like to introduce the speaker, none other than Dr. A.K. Singh, who is a senior consultant at GD Hospital and Diabetes Institute, Kolkata. He will be talking on the role of hemoglobin in diabetes management. Over to you, sir.
Good afternoon. Can I have my slide, please? Thank you. So this is a new molecule. If you have heard the name of this molecule called imeglin. Imeglimin is a new kid in the block for the treatment of diabetes. This is a unique drug. And I will explain you why this is a unique drug. No drug in the past for the treatment of diabetes worked in a fashion as to how imeglimin works. It's a mitochondrial powerhouse in type 2 diabetes. So the little story about this molecule, it was approved in Japan in June 2021, brought to India and was approved by DCGI in September 2022. The approved dose is 1 gram twice daily in people with type 2 diabetes whose kidney is perfectly fine. You can reduce the dose to 500 milligram twice daily in patients whose eGFR is less than 45, less than 60 or more than 45. But it should not be used in people with CKD with eGFR less than 45. The reason being that this has not been studied in patients with eGFR less than 45. It's not that it increases kidney outcome or it increases kidney failure, but it has not been studied below less than 45. Now, as I said, this is a unique medicine which works in a very distinct direction. This is the only drug for the treatment of type 2 diabetes which is not only insulin secretagogue, but it's also insulin sensitizer. So if you look at the treatment of type 2 diabetes today, either it is insulin sensitizer like metformin or pioglitazone, or insulin secretagogue like sulfonylurea or a GLP-1 receptor agonist or DPP-4 inhibitor. They are either secretagogue or insulin sensitizer. A GLT-2 works directly on kidney. It has got no role on beta cell. So it's neither an insulin secretagogue nor an insulin sensitizer. But imeglimin is a both insulin secretagogue and insulin sensitizers, and therefore this is the unique drug for the treatment of type 2 diabetes, which works on both insulin resistance as well as insulin secretion. So you can look at this beautiful cartoon we published in 2023, how it works. So this is a drug that works on beta cell in pancreas. This is a drug that works on liver to reduce hepatic glucose output. This works on the skeletal muscle, reduces insulin resistance. No drug works in all these three organs together. That's the beauty of this drug. If you closely look how actually it works, I don't want to bore you, but you can read this paper which we published. There is a various mechanism by which imeglimin controls diabetes. And the good news is that this is a drug which actually boosts your mitochondria, be it in a beta cell, be it in a skeletal muscle. This boosts your mitochondria by increasing ATP inside the mitochondria. This is a class of drug which has got no exact categorical classification. So this is a drug Z, which is basically a kind of unclassified drug, but it works very similar like metformin. But it is also different from metformin that it do not increases lactic acidosis. The metformin is one of the drug that works on mitochondria, as the imeglimin works. However, imeglimin do not produces lactic acidosis unlike metformin. So there are a number of studies conducted in a supra-pharmacological dose to look whether imeglimin has any ability to increase lactic acidosis, because it works in a similar way how metformin works. However, metformin is a purely insulin sensitizer and not a secretagogue. So let's look at that how we are claiming it. Is there any evidence that this is a drug which works on both insulin secretion as well as insulin resistance? There are some studies that looked into that and to claim this is how imeglimin works. So you can see this was a first study to look at how imeglimin might be working. And if you look at this graph, I will explain you what is happening here. So in this graph, you can see imeglimin was compared to placebo, and the patient's plasma glucose was increased in a hyperglycemic clamp. So you inject glucose, increase the blood sugar level, naturally then insulin will come out to protect you, and look at what happens to the insulin secretion after giving imeglimin. Now what did you look here? So you can see on your bottom hand side, this is insulin. You can see there is a clear peaking of insulin when you gave imeglimin tablet. And if you exactly calculate that after 7 days of imeglimin, there was a 110% increase in first phase of insulin secretion, 29% in second phase, 36% in insulin sensitivity of beta cell. So this is a first proof of concept study that suggested the imeglimin is both insulin secretagogue and as well as insulin sensitizer. This is another study that looked into the same direction to prove that imeglimin is a both insulin sensitizer as well as insulin secretagogue. Now you look, this is on your upper hand is insulinogenic index. This suggests that how much insulin is secreted when you give imeglimin tablet against placebo, and you can see there is a significant increase in insulin secretion. If you go to the bottom side, you can see there is an increase in a Stump-Hall index. This is one of the way to measure insulin resistance. So you can see in a same study, the drug is showing that this is reducing insulin resistance as well as increasing insulin secretion. Now whether this translates into any clinical benefit, as a clinician this is what we are interested. So I will show you some of the phase 2 clinical studies where imeglimin was tested. So this is a double-blind randomized controlled trial looking at the various dose of imeglimin in people with type 2 diabetes, and as you can see, the HbA1c drop was not less than 0.9 to 1% with imeglimin 1000 milligram twice daily or 15 milligram twice daily. Because if you look at this, dose finding study and look at the GI side effect to compare which dose to be chosen in clinical practice, because the GI side effect was, as you can see, pretty less with the 1000 milligram twice daily with a similar HbA1c drop of 0.91%, the dose of 1000 milligram twice daily was chosen for the clinical use. This is the reason as to why imiglamin should be used 1 gram twice daily based on this phase 2 ascending dose trial. Now, so then when the 1000 milligram imiglamin was tested in a phase 3 clinical trials, so the imiglamin trials is popularly known as TIMES trial. This is a times 1 trial, as you can see, conducted in people with type 2 diabetes in Japan against placebo. There was a significant reduction in HbA1c by 0.7% compared to placebo. If you look at the placebo subtracted change, it becomes to 0.85%. 0.8% HbA1c reduction in diabetes is a phenomenal. It's a phenomenal difference in HbA1c difference when you looked at the imiglamin, thereby suggesting that this molecule has got a definite place in the treatment of type 2 diabetes. So this was a times 1 trial conducted against placebo in people with type 2 diabetes who were treatment naive. Now the second trial, this is called times 3 study, was done whether these medications also work with insulin. The patients with type 2 diabetes receiving insulin in whatever form, basal insulin or premix insulin or basal bolus regime, when they were randomized to either imiglamin 1000 milligram twice daily or placebo, there was a significant reduction in HbA1c. This suggests that in people who are a long-standing diabetic, type 2 diabetes requiring insulin, the imiglamin works in a long-standing diabetic patient. This suggests that if your patient is on insulin, by virtue of their insulin sensitizing activity, the imiglamin reduces the HbA1c by 0.6%. And the third trial is called times 2 trial. This was the largest trial conducted with imiglamin till date, where imiglamin was tested with all types of anti-diabetic drug in combination. So as you can see, imiglamin was tested with as a monotherapy or combination with alpha-glucoside inhibitor or with bigunide or with DPP-4 inhibitor, with glinides, with SGLT2, with SU, with TJD, with GLP-1, everywhere in combination with any anti-diabetic drug, there was a significant HbA1c drop. The only HbA1c drop which was less significant was with GLP-1. And I will explain you why it was less with GLP-1. But barring the GLP-1, if you look, the HbA1c drop with imiglamin, it was highly statistically significant. And the largest reduction happened with the DPP-4 inhibitor along with imiglamin. Finally, when you look at the evidence, you always look at the meta-analysis of randomized controlled trial. So we were first to do this meta-analysis in the world to look at how imiglamin works. We published this paper. When you look at the evidence with imiglamin through these 3 randomized controlled trial done with 1000 milligram twice daily, you can see there is HbA1c drop of 0.9% with imiglamin as a monotherapy, suggesting a clinically meaningful, significant HbA1c drop with imiglamin, although this is based on the pooled data of only 2 randomized controlled trials. When you combine all the RCT done together with imiglamin, again we can establish that there was 0.8, 0.9% HbA1c decrease with imiglamin. These overall evidence suggest that imiglamin work regardless of whether you have got a newly diagnosed diabetes or you have got a longer duration of diabetes. It worked at every spectrum of type 2 diabetes. There is a CB safety studies done with imiglamin as well, as you know, because this was approved in Japan. In Japan, you don't need to conduct a cardiovascular outcome trial unlike US FDA. So in Japan PMDA requires a QT prolongation study. So every drug that has to be approved by Japanese authority has to undergo a QT prolongation trial compared with moxifloxacin. You know, in whole pharmacology, the drug which has got a highest ability to prolong QTC is moxifloxacin. So every drug has to be tested in a head-to-head trial to look whether the drug has the ability to prolong QT. In this trial, on a supratherapeutic dose, there was no QT prolongation whatsoever with a 8000 milligram dose of imiglamin compared to moxifloxacin. And you can see the top moxifloxacin causing significant. So ladies and gentlemen, to conclude my presentation, imiglamin is the only oral anti-diabetic drug today in the treatment of type 2 diabetes that increases both insulin secretion and insulin sensitivity through a novel mechanism. With the evidence available so far, both efficacy and safety data of imiglamin looks promising. 0.8, 0.9 is a too good HbA1c drop. It appeared effective in any combinations of drug, be it metformin, SU, glanids, pioglitazone, DPP4, SGLT2 and insulin. The only point where we need to ask this question is where to put this drug in the treatment of diabetes in terms of positioning. So the positioning in the treatment algorithm of type 2 diabetes is yet to be settled with imiglamin. So we need more data where to put this imiglamin in the treatment of type 2 diabetes, but the data suggests that whether you're using in a treatment naive, to people receiving insulin, everywhere imiglamin works. Thank you very much for your patience.
So thank you, sir. Thank you, sir, for excellently covering all the aspect. So we can take 1 or 2 questions from the floor.
I'm coming. Give me 30 seconds. Quick question, please. I have been called from the room, main room. Yes. So imiglamin can also be given with metformin. There are 2 trials, randomized trial done with imiglamin along with metformin, and there was additional HbA1c drop with metformin. This suggests that imiglamin also works through beta cell where the metformin doesn't work. So metformin is insulin sensitizer. Imiglamin is both insulin sensitizer as well as secretagogue. Therefore, at the top of metformin, there was additional HbA1c drop with imiglamin. So there is a trial already with metformin. You can use it. So as I said, in CKD less than 45, we have no studies so far, so it is not recommended in less than 45. In less than 60 to 45, you need to reduce the dose to 500 milligram twice daily. We don't have any study.
Okay, thank you, sir.
Quick, please.
Before food or after food?
So imiglamin also have got a GI side effect like metformin, but it is much less compared to metformin. So there are many patients who are not tolerating metformin are the good candidate for imiglamin. So GI side effects are much lesser with imiglamin compared to metformin. Now, because there is a GI side effect, you must use it after the meal.
Sir, when you use insulin, we may reduce dose of insulin or the insulin same?
Right. So if your patient has got a good HbA1c on insulin and you wish to add imiglamin, then of course you need to reduce the dose of insulin. But if your patient is already on insulin but not able to achieve HbA1c target, why should you reduce the dose? Then add the drug.
That is why we add imiglamin.
Right.
Thank you, sir.
So thank you very much.
Thank you, sir. So we will come to the last leg of today's session, mixed bag. I would like to call upon the chairpersons, Dr. Manisha Gupta and Dr. Dhruvi. Dr. Manisha Gupta is consultant at Dr. Manisha Gupta's Diabetes and Hormone Clinic at Kanpur, and Dr. Dhruvi is a well-known consultant of Rudraksh Institute of Medical Sciences. Over to you, ma'am.
Thank you so much. Thank you. We have the pleasure of inviting our very own Dr. Arundhati ma'am. We've had the experience of learning from her at one of our endocrine summits. And yes, ma'am is an MD medicine endocrinologist, director and consultant endocrinologist for Rudraksh. Ma'am, same pinch for the name of the institute. She has her A.V. Gandhi Award in 2012, Diabetes Initiative Awards, a plethora of awards in her name, a lot of presentation. She's been the course coordinator for PHFI and a lot of publications to her name. With that, we look forward to hearing from you, ma'am.
Thank you so much, Dr. Dhruvi, for that kind introduction. So, reaching the fag end of the day, I'll be talking to you about saroglitazole. This is the country's own molecule, and it is a dual PPAR gamma agonist. We'll take a look at what is its role, where does it stand in our practice, does it have any position in, in our usage with our patients, anything beyond fatty liver or in fatty liver. So when we talk about a background of a metabolic disease, and we cannot look away from the ICMR data, which has given us a very comprehensive idea about how the metabolic conditions are growing in our country. And we've seen that 81% of Indian adults have dyslipidemia, low HDL and high TG, which is the prevalent pattern, and you can see there. So when you say a significant number of more than 80% of people in a country have dyslipidemia, that's really, really saying a huge number is there, huge burden is there. There is no need to explain this slide. This has been shown 1,000 times, but the significance of this slide doesn't go away. Every time we understand it, every time we talk about metabolic conditions, the YY paradox stands out, reminding us why we should not take data just blindly from the West, how we are very different, you know, in terms of our metabolic pattern, in terms of our thin fat pattern, in terms of our early decline of the beta cell mass, our dyslipidemia, our diabetic pattern, which is slightly different from that in the West, which is why our patients may behave differently from that in the West. So this is a study in urban India where they looked at school children. Now remember, just a few years back, we were a country where we were talking about malnutrition, we were talking about undernutrition in our country. Fast forward to today, we are talking about a prevalence of obesity, which is to the tune of 28.2% in the age group of 6 to 16 years. And if you're talking about metabolic syndrome, that's to the tune of 21%. 32% at a HOMA-IR of more than 2.5. These are very significant numbers because they are telling us what the future is going to be. Our children, 28%, like more than 1/4 of our children are in that, category where immediate action needs to be taken because they are already not in the overweight category but in the obese category with all the metabolic dysregulations happening. Now we do know that insulin resistance forms a root cause of the pathways leading on to diabetic dyslipidemia because we're talking about hyperinsulinemia, more of insulin, more of the pathway, SREBP pathway being triggered, and then you have hyperglycemia, that is again triggering the CHREBP pathway, attacking the liver, leading on to steatosis, fat liver, NASH, lipotoxicity, and end-stage liver disease. Add to that the genetic predisposition and the environmental factors, all of it leading to a major step forward, leading on to an exaggerated, push forward towards end-stage liver disease. Now, this is the burden of diabetic dyslipidemia, and actually maybe much more. And if you're talking about MSA-ALD now, add to that diabetic dyslipidemia, India actually faces a very, very grim picture. This is the prevalence rate, 34.2%. We do know the LDL and the small dense LDL, the rise in the triglyceride and the low HDL. That's a typical picture of the diabetic dyslipidemia in our country. And it is a little different from the Western world. And of course, they have been found to have higher levels of HbA1c correlating to levels of more than 8%. So this was the first study which was done with saroglitazar. And they had shown the early and sustained, it's not the first study, but one of the first major comprehensive studies which looked at the early and sustained benefits of saroglitazar. And they took a baseline BMI of 28, right, at an age of 54, mean age of 54, and they used saroglitazar over a period of 36 months. And what was seen was that 72% patients achieved a triglyceride target of less than 200 at the end of 3 years. The creatinine remained neutral. There were no major adverse effects reported. And there were only 2 patients who did have a reduced ejection fraction or edema, because since it's a molecule similar to pioglitazone, a little bit different, there were concerns about heart failure and edema and others, but that was not significantly seen in this study. So it's being said that fatty liver is the new diabetes. What does this mean? This means that, when you're looking at fatty liver, just don't look at the ultrasound picture which says, grade 1 fatty liver and just look through it and worry about the HbA1c, the LDL, the creatinine and everything else. You need to be equally concerned because this is what we are understanding today is that the root cause, the root, the soil from where the entire damage is starting off is somewhere in the adipocytes, and that has a lot to do with the steatotic liver disease, which has more than 5% of fat in the liver. And when you add to that one cardiometabolic risk factor, whether it's elevated triglyceride or low HDL or type 2 diabetes or obesity or hypertension, then you develop what is known as MASLD. And it is important to understand the significance of MASLD as different from a simple fatty liver that we understood for years, and because we know that what it can lead on to. This is the MAP study, looking at the pan-India prevalence of MSLD or fibrosis or cirrhosis across the population who are visiting our centers, the diabetic and the endocrine centers. So they saw a prevalence rate of 68%. But how many patients are you diagnosing in your practice? When you're looking, we are very seriously looking at all the other markers. But when it comes to liver disease, are we not missing out a significant number? Because they're telling us 68.2% are actually the category of MSLD. 33%, that means 1/3 of our patients, our diabetic patients coming to us, are already in the stage of fibrosis, while 12% are in the stage of cirrhosis. And when we talk about the risk associated with fatty liver, the patients are, the chances of them dying of a liver disease is much less as compared to the chances of dying of a cardiovascular disease, a peripheral, an ischemic stroke, a cardiac arrest. Leading on to ESKD, you can see the numbers there, 80%, 75%, 60%. So when you're seeing an MSLD, you're not just concerned that, okay, this person will go on to cirrhosis, and then you're very much concerned about what this is brewing. This liver, what is it brewing? What is it sending out? The free fatty acids, the inflammation markers, what is it sending out and causing, a disruption in the entire cardiometabolic pathway? That is what we are concerned about, because we know that MSLD patients are twice more prone to develop ESRD, with a worse CKD prognosis also. Also in our diabetic patients, as compared to non-diabetic patients, the pathway from NFLD leading on to cirrhosis or HCC, it's much faster, it's much more. So while you would have a transformation from NFLD to NASH in 10 to 20% in a non-diabetic population, in the diabetic population, it would go as high as 40%, leading on to 20 to 25% case of cirrhosis, 5% HCC, and mortality levels you can see much more triggered, much on the higher side as compared to a non-diabetic population. So again, every diabetic patient coming to you and looking, that benign looking fatty liver in the ultrasound may not be that benign. It is important to look at it in a proper way, assess it, and understand if it needs, any kind of treatment. And that is why the clinical practice guidelines have come forward. They've said that any diabetic patient or patient or person with obesity with one risk factor or with elevated liver enzymes should be evaluated for the risk of fibrosis or for the risk of MSLD. And what do? You do something as simple as a FIB-4 scoring. Just simple put in the values, because definitely you're getting a platelet done, you're getting an SGOT, SGPT done in your assessment. Just put in the data there, look at the FIB-4 index. If it is indicative, if it's more than 2.6, then you go ahead and assess. 1.4 to 2.6, you would follow this up, and less than 1.4 puts it in the safe category. So that is how you would assess it. Now coming to this molecule saroglitazar, which basically has been seen to attack 3 areas: the insulin resistance, the diabetic dyslipidemia, and the MSLD. So basically, when you are looking at the usage of saroglitazar, you're talking about setting 3 targets in one shot. So has it, redefined? Well, we've had recommendation for usage in diabetic dyslipidemia in 2013. In 2020, type 2 diabetes also came into the area where saroglitazar could be used as an add-on to metformin. And 2020 December, we had MFLD expanded into the list of indications where saroglitazar could be used. So what is saroglitazar? It's basically a dual PPAR alpha and gamma agonist. It's through the alpha action, it's basically taking care of the triglyceride. Through the gamma action, it's targeting the insulin resistance and thereby controlling the blood sugar. So when you're looking at these 3 areas, insulin sensitization, HbA1c reduction, and improvement in the diabetic dyslipidemia status, these are the studies that have been done. This is an randomized controlled trial, a placebo-controlled trial. And here the baseline HbA1c was 7 to 9 and a triglyceride level more than 150. They were given saroglitazar vis-a-vis placebo. For 4 months they were studied, and then what was seen was that the insulin sensitivity with the usage of this medicine was better. Glucose metabolism also was seen to fare better with the usage of saroglitazar. This is again looking at the review analysis of 18 clinical studies over a spectrum of 5,800 patients. These are the data. So triglyceride 45 to 60%, non-HDL 21 to 36%, small del NSDLs 20.3%, HbA1c 0.7% reduction, up to 1.6, maybe in very rare cases, but generally up to around 0.7, and ALT reduction 28 to 67%. The question being, why not fenofibrate? Now, of course, fenofibrate is only targeting one part of the the story. But again, if you're comparing the triglyceride reduction from baseline, saroglitazar versus fenofibrate 160 milligram, you can see in this particular study, which was done in Mexico, the reduction with saroglitazar was actually a little more, and then that was seen with fenofibrate. This is RSSDI 2022 guidelines, again putting in saroglitazar strongly in the indication for high triglyceride. The role in fatty liver, MSALD, ALT, AST reduction in fat, the liver content of the fat, and fibrosis reduction. So this is what has been seen, 67% of reduction in AST, ALT compared to 40% with UDC. Of course, we're not using UDC a lot today, but this was the evidence 2 study, which was basically the first study which was biopsy driven and showed us that with the usage of saroglitazar, there was definitely improvement in the NA score, which was, the biopsy parameter which was seen. This was a study done in Kolkata. This is a small study, 112 NFLD patients, but the CAP and the LSM scores were evaluated. It was seen to be much better with the usage of saroglitazar. Another study, 144 weeks follow-up, significant change in liver fibrosis over a period of 144 weeks in terms of LSM and CAP. And then we had the evidence 9, which was basically 1,500 patients, 19 centers, saroglitazar. And you looked at the FibroScan data over a period of 24 weeks, it was definitely seen that there were reductions in terms of these parameters, the reduction minus 2.2 and minus 3.3 kPa being seen there. So thereby, 2022 guidelines recommended saroglitazar for the treatment of MSALD because it causes significant reduction in fibrosis and liver enzyme levels because of the evidence shown in the evidence 2 trial for a minimum period of 12 months. It has been found to be safe in CKD patients also. These were studies which were done in CKD patients. No concerns. In fact, the p-values were absolutely safe. Just one or two more slides here. So they were absolutely safe during the 12-month period, thereby reducing concerns about whether you can use it in patients with a lower GFR. And this, you can see there's significant reduction in fibrosis obtained without any change that has been seen in creatinine, with benefits in HbA1c, with benefits in terms of insulin resistance. So that is the Lead India EMR data also being seen, similar results being seen. So thereby, as we summarize what we have understood about the usage of saroglitazar in the last so many years, about whatever studies have been done, so we know that given our background, our metabolic symposium, higher risk of insulin resistance, higher consumption of carbohydrates, also high triglyceride, and the high prevalence of diabetic dyslipidemia, with the high levels of the MSALD that is also being seen across various studies that have been done, saroglitazar is a good solution to a lot of these pathways. It's not the best solution, it's not the only solution, but it is a significant solution when you're talking about treating diabetic dyslipidemia and a combination of MSALD with some amount of benefit being given in terms of HbA1c reduction also. So on that note, thank you so much, and I'll hand it back to the chairpersons.
Thank you so much. We'll just take the question after Salima ma'am.
Moving to our next speaker, I would like to invite Dr. Salima S. Tarenia. She has done her MD in General Medicine, DM Endocrinology, DRNB Endocrinology, and attached to Medica Super Speciality Hospital, TMC, Kolkata. She has various publications, authors many chapters and books, speakers and panelists in various conferences. Over to you, ma'am.
Thank you, Chairperson. So very good evening, and I think this is the last session with the audience thinning and also a boring topic to handle, so I'll just try to bust through quickly. My topic is endocrine abnormalities in patients with immunotherapy. So over the last couple of decades, immunotherapy has proven to be one of those powerful tools who have helped us in fighting cancers, handling cancers. So what do these do? They basically block the immune checkpoints and release the T cells to go and fight cancer. But what we need to remember is that these immune checkpoint inhibitors, or rather these immune checkpoints, they promote self-tolerance and prevent autoimmunity. So when we're dealing with an immune checkpoint inhibitor and these areas being inhibited, that is going to lead to autoimmune side effects which can affect the endocrine glands as well. Most of these endocrine abnormalities that we would be finding would be associated with the CTLA4, PD1 and PDLA1 inhibitors. So to discuss in short details, thyroid dysfunction is one of the most common, rather the most common abnormalities of endocrine function which is associated with immune checkpoint inhibitor therapy. So it ranges from overt hypothyroidism at one end to overt hyperthyroidism at the other end, and in between we also have the thyroiditis as well as the subclinical hypo and hyperthyroidism. Now amongst them, hypothyroidism is more common. This can be preceded by a transient thyrotoxic phase, which might eventually land up in euthyroidism, or it might even lead to a permanent hypothyroid state. So now coming to the anti-TPO status, so we find that about 18 to 40% of these patients have anti-TPO positivity, but when it comes to Graves' disease, it's rather rare, and very, very few cases we've got anti-TSH receptor antibody status being positive. What are the signs and symptoms? So both ICP-related thyrotoxicosis as well as hypothyroidism are rather mild, and we have non-specific symptoms. We can get heat intolerance, tremulousness, tremor, anxiety, hyperdefecation, rarely thyroid storm, very, very rare. This is in case of thyrotoxicosis, whereas we can get fatigue, weight gain, cold intolerance, dry skin, and constipation in hypothyroidism. So what is very important is that we need to monitor the thyroid function test. We need to run in a free T4, a TSH, and in cases where we're suspecting hyperthyroidism or thyrotoxicosis, we need to run in a T3. Now, most of these cases where we suspect hyperthyroidism, usually it's transient. So we do not need to manage with antithyroid drugs, except rarely if there is Graves' disease. Otherwise, beta blockers would suffice, and glucocorticoids if in the account there's a severe thyrotoxicosis spell, or if the patient is having elderly patient who's suffering in a very bad way. If there's hypothyroidism, we again need to keep in mind whether it is transient or not. If it is permanent, then levothyroxine replacement needs to be done. So do we need to stop immune checkpoint inhibitors? Therapy should not be stopped, only to be interrupted in cases of severe thyrotoxicosis, which is again very rare. Now coming to diabetes. So immune checkpoint inhibitor diabetes is rare, but it is potentially life-threatening because it presents almost similar to that what we face in fulminant type 1 diabetes, and it's mostly autoimmune mediated. So how does it present? Basically, there's a very rapid onset of hyperglycemia. It can be within days to weeks, and there is swift progression to endogenous insulin deficiency, and you also have a very high risk of decay. That is why whenever these patients are being managed with ICP, that is nivolumab, pembrolizumab, etc., we need to counsel the patients as well as the family members that there is a possibility of development of diabetes, so they need to watch out for symptoms of polydipsia, polyuria, etc., because in these cases when we would be measuring, the patients might directly come with a very high blood sugar levels or even a DKA, but the HbA1c might be normal because the onset is very, very rapid. So how do we diagnose? Like I said, HbA1c at times might be misleading because sometimes the onset is very, very abrupt and it's very serious. It can even land in TKA. C-peptides would help to some extent. Pancreatic imaging might be positive, might give us some idea about any inflammation which is ongoing. Autoantibodies, they've seen that in many cases autoantibodies are actually positive. How do we manage? Like I just mentioned, counseling is very, very important. Insulin is the only way of management to bring down the blood sugar levels. DKA management is very important. Hydration is to be done. ABG, electrolytes, etc. have to be monitored. And we need to keep in mind that there is no role of corticosteroids over here. Coming to the next one, that is hypophysitis. So this is again a very common side effect of immune checkpoint inhibitors. So basically, it's inflammation of the pituitary gland, and what we need to keep in mind is that incidence of the hypophysitis is more common when we are using these agents in combination rather than using them alone. And if it is alone, then CTLA4 inhibitors, that is the ipilimumab, is associated with hypophysitis. It is more common in men, and the pathology is both through the ADCC as well as the complement pathways. Now, what is challenging is the symptoms, because when these patients are coming with a hypophysitis, it's very difficult to understand because they'll be presenting with non-specific features like headache, fatigue, and in contrast to the other forms of hypophysitis like the lymphocytic hypophysitis, where we get a mass effect because the pituitary is enlarged and it's going to impinge on the optic chiasma. That's going to lead to headache, that's going to lead to visual abnormalities. But in this case, we don't really get any mass effects because the enlargement of pituitary is not that big. Secondly, coming to the other sequences, that is central hypothyroidism, central adrenal insufficiency, and hypogonadotrophic hypogonadism. So we need to be very careful about both central hypothyroidism as well as central adrenal insufficiency. Central hypothyroidism usually in this context is transient. So we need to keep on monitoring for the 3-4 levels, because again, in cases of secondary hypothyroidism, TSH doesn't really help us. And another issue which we very commonly face in this background is how do we differentiate it from sick euthyroid syndrome? Because these patients are usually unwell, they're admitted for a couple of days. So it's very difficult to understand that whether it is actually a secondary hypothyroidism which is there, or is it just another sick euthyroid syndrome which is playing. After this is secondary adrenal insufficiency. So this is again very important because it is actually the main cause of morbidity as well as mortality if it is not really attended to. And in this context, even situations become worse when we really cannot understand, we really cannot figure out, because what we need to know is that the cortisol, which you need to check here, is going to be low. But in some instances, it might not be low because the patient might be getting some other form of steroids. Sometimes we might need to run in a synactin stimulation test, where what do? We inject a 250 microgram synactin and we run in the cortisol levels at 0, 30 and 60 levels, so at 60 minutes. And if the cortisol value crosses to 18 microgram per DL, that means the axis is intact. But what happens in these cases, the secondary adrenal insufficiency, the duration might be of a very, very small time, maybe within a few days. So the adrenals have not got enough time to shut down, and in that case, the test can be falsely positive. Again, most of these patients, when they're receiving any kind of chemotherapy, immunotherapy, they're already receiving another steroid, say for instance a dexamethasone or a prednisolone, and that also might interfere with the interpretation of the test. So whatever be the matter, if our clinical judgment is leading us to feel that this patient is having some form of adrenal insufficiency in the form of hypotension, hyponatremia, hypoglycemia, it is always better to administer hydrocortisone or any other form of steroid which is available to save the patient from crisis. Now coming to hypogonadotrophic hypogonadism, this is again not very common. So in this case, we would not be getting the, say for instance, it's an elderly patient and we need to check for the FSH or the LH, and that would not really be that high. But then again, if the patient is admitted for a long time, so the chronic disease might also affect the status. So it's very difficult. Coming to growth hormone and prolactin, these are very, very rare. And even coming to ADH deficiencies, we've rarely encountered. So how do we diagnose and manage? If we look at the pituitary enlargement, it might even precede the symptoms. So, but then we don't really run in an MRI for everybody. But if it is possible, then we need to go for a serial MRI, because usually the pituitary mass lesion which comes, it slowly starts to resolve within weeks to months. Usually we have an enlarged pituitary and stalk thickening might be rare there, but chiasmal impingement is rare. So this is important, and while monitoring, we can go for both the free T4 as well as the cortisol. So how do we replace? We start with a levothyroxine of 0.8 microgram per kg. But if the patient is having a concomitant glucocorticoid deficiency, then we need to replace with the glucocorticoids first, otherwise the patient would land up in a crisis, and then we need to start with the levothyroxine. So we need to start it with the lowest dose. What is the rationale? Because just like I mentioned, that majority of the cases, the hypothyroidism, central hypothyroidism is rather transient, and we can actually slowly up titrate it, and the consequences are not really related to the dose. That is, whether we initiate at a lower dose or at a higher dose, the outcome is not going to vary. So, and also like I mentioned, monitoring of free T4 is very important, because in a secondary hypothyroid, TSH doesn't really help us. Coming to replacement of glucocorticoids, this is very, very important because the patient can land up in crisis. So that has to be done. HP axis monitoring has to be done as per protocol. Now coming to testosterone therapy in men, if they are of younger age, then this can be taken into account. But we need to remember that glucocorticoids and levothyroxine, they have to be replaced. So now coming to the primary adrenal insufficiency, this is seldomly reported, and it lands up in adrenal crisis. Now, how do we differentiate it from secondary adrenal insufficiency? In primary adrenal insufficiency, we get a low cortisol, whereas the ACTH is elevated, and we get a higher degree of hyponatremia. We can go for an imaging, which is going to give us an idea if there is bilateral adrenal enlargement, there's nodularity, metastasis, etc. But what we need to remember is both glucocorticoids as well as mineralocorticoids need to be replaced in primary adrenal insufficiency. Now, my last two slides, parathyroid. Hypoparathyroidism is a very, very rare event, and management should be done along the lines of acute hypocalcemia. And last but not least is the glucocorticoid. So this is very, very commonly used in cancer setups with chemotherapy, immunotherapy, etc. So two most common damages that we have to handle is hyperglycemia, which has to be managed on the day-to-day and variation basis. And another is osteoporosis, which many a times we tend to ignore. Patient is getting long-term steroids or getting intermittent steroids and lands up in a fracture. So it's better to run in a DEXA scan. And risk of adrenal suppression, because in these patients, the adrenals tend to be suppressed, and we need to replace them with the physiological dose of hydrocortisone along with a 3 to 6 monthly monitoring of the adrenal axis, whether it has recovered or not. So thank you very much for your patient hearing.
So hall is open for question, if at all we have any. Wonderful presentation, ma'am, and like the way you mentioned about hypophysitis, which is really very less spoken about. Really loved it. Thank you so much for a very lucid presentation. So if we do not have any question, can we close the session? Thank you so much.
With this, we would close the session in this hall, and I would like to request all the delegates to move to the main hall for the rest of the proceedings.